let's start now. So my name's Kirthi. I'm a current FY3 working in Birmingham who's interested in peds. So I'll be doing a bunch of peds teaching scenarios for you guys. Just a quick little history of obviously biomedicine, which you guys know about. We've got a question bank. They have an online textbook. They've also started a feature where you can edit topics as well as you go along. So you can write notes alongside it. And they've got, I think, around like 600 topics that you can go from. So there's loads to choose from. So have a little quick look after you do this session. So quick aims and objectives. So we're going to be focusing on chronic asthma at the moment. So we'll do pathophysiology, risk factors, and then go into investigations and management according to age. I'm going to sprinkle some single best answers as well, so we can do some questions together. And then we'll try and keep it really short, like 30 minutes, because I've found from experience as well that keeping it short is when most information goes in. At any point, if you want to just ask any questions in the group chat, feel free, go ahead, and I'll either answer them at the end or throughout as we go along. So however you guys want to do it. Okay, so we'll start off with a question. So this is a 7-year-old boy who's come to the GP with a 5-day history of intermittent breathlessness, wheeze, and chest tightness, and he had a sore throat a week ago. So prior to this, he occasionally would get wheezy with a dry cough, particularly worse at night. So other than a history of eczema, he's otherwise fit and well. On examination, he's got no respiratory distress and his observations are completely normal. So this is the boy that we're going to be following as we go along with our presentation today. So just having a look. So with our first question, I know I've not really talked about it yet, but just to kind of see where you're at. So which of the following is most implicated in the pathophysiology of chronic asthma? I've not kind of set up a Mentimeter for today just because we're keeping it quite quick and rapid. So you can either kind of write it down or put it in the group chat, however you want to do it. I'll give you 10 seconds to answer and then we'll move on to the actual answers and go through it that way. So, oh yeah, someone raised their hand. I think you can unmute yourself. Oh. Does someone want to say anything? I think, because I don't know if I can, or just you can write in the group chat if there's any questions you wanted to ask. Okay. So which of the following is most implicated in the pathophysiology of chronic asthma? So is it IgE mediated activation of eosinophils, IgG mediated activation of macrophages, IgE mediated activation of mast cells, IgM of neutrophils, or IgA of eosinophils? So on to the answers. So the third one is the correct one. So IgE mediated activation of mast cells. So let's go into the pathophysiology in a bit more detail. So asthma is characterized by chronic airway inflammation. So it's a complex interaction between genetic and environmental factors, and it's driven by atopy and exposure to allergens. So atopy just refers to this genetic tendency to develop allergic diseases. So this heightened immune responses to common allergens. And examples of atopic diseases is like eczema, hay fever, allergic rhinitis. So it's kind of driven by atopy with asthma as well. So going into a bit more details of what exactly is involved. So you've got expressions of the T helper 2 cells. This is kind of going back to like first year or second year, depending on where you're at. And this is in genetically susceptible individuals. So following from that, you get this cascade of inflammatory mediators released from the Th2 cells, and that involves interleukin 3, 5, 10, and 13. And then following from that, that's what causes the smooth muscle spasm and increased mucus secretion in the bronchioles, resulting in reversible airway obstruction. So in the many airway diseases, asthma is one that is a reversible one. And then a bit more just about what happens acutely is when in an acute setting, allergens, when you're exposed to allergens, they bind to the IgE antibodies, and this causes a mast cell activation and degranulation. So that basically just means that there's also a release of these inflammatory mediators, and that can involve like leukotrienes as well. So going back to our first one where we talked about Th2 cells over here, the same ones again. So when they had released this interleukin-5 in an acute setting, it activates eosinophil production, which promotes the late phase reaction. So that's basically that acute symptoms in asthma. And then just a little kind of statistic when it comes to asthma. It's something that you will face whether you want to do GP, pediatrics, A&E. It's the most common chronic condition among children and young people, with around like 1.1 million children currently receiving asthma treatment. So it's definitely a hot topic when it comes to MCQs as well. So very useful to kind of have a good understanding about. So just going back to that first question again, so we talked about what was most implicated in the pathophysiology. It's just a little breakdown as to why the other ones weren't correct. So with the Ig-mediated activation of eosinophils, yes, eosinophils are involved, but not particularly in chronic asthma, more to do with acute asthma. And then with IgG-mediated activation of macrophages, as we kind of saw, macrophages weren't really mentioned because they're less significant when it comes to asthma. IgG is actually known to act during asthma when it comes to mediating inflammations, but with the macrophages part, not so much. And then IgA mediated activation. So IgA isn't particularly associated with pathogenesis of asthma. In fact, it actually has a protective factor because it can actually help to protect the mucous membranes. So if you were to do a blood test, a low IgA level is actually associated with increased asthma severity. Just a fun fact, it's not really something you need to know. And then IgM mediated activation of neutrophils. So neutrophils are less significant when it comes to the inflammatory response. So IgM can be noted to be elevated in asthma because they are produced by the local plasma and epithelial cells, but it's kind of a bit unclear as to why that is. And then finally, our answer, Ig-mediated activation of mast cells. So it's the mast cells that tend to act most when it comes to an asthma. So going on from the risk factors, we talked about, so we'll start from the beginning. So I guess personal family history of atopy, I kind of mentioned this at the start, just having that history of atopy, the fact that you've got this heightened response when it comes to allergens. So that's one of them. And then trigger factors can include smoke, tobacco smoke, cold weather, exercise, pets, dust mites. So whenever you're taking a history from a child, especially whether it's in an acute setting or just in a GP setting, always important to be aware of what the trigger factors are so that they're aware of it as well, so that they know to expect it, so that they know to take their inhaler with them, even though they should be taking them wherever they go. So always good to ask about their trigger factors as well as family history, because having a family history of atopy hugely increases your risk of having an atopic disease such as asthma. So it's very much tied in. So as we said, not only if you're smoking it yourself, but also passive smoking. And then antenatal factors are known to play a role too. So maternal smoking, RSV during pregnancy, and then low birth weight is one of them. Bottle fed, so breastfed is meant to be a protective factor. Significant allergen exposure, so that can be dust mites. So always to know about, again, when you're taking histories, to know about social situations too, what their housing is like. Sometimes they kind of, parents, if they know, they kind of say it themselves that they're concerned about it. But yeah, certain housing situations can definitely exacerbate asthma. Air pollution, I think a lot of people, especially now with a lot of studies, have found that places like London, where there's a lot more pollution, has been shown to cause a lot more respiratory diseases. So exacerbation of asthma is definitely very much an issue because of the pollution. Childhood viral respiratory illnesses. So it's kind of a bit controversial in terms of whether it is or not an issue, but evidence suggests that if children did have infection with RSV earlier on in childhood, it may increase your risk of developing asthma at a later stage. And then the hygiene hypothesis, this is basically where there's an increased risk of asthma noted in the developed world, mainly because there's reduced exposure to pathogens across childhood. So in general, exposure to pathogens, I guess, is good because your body can recognize what is harmful and what's not harmful. But I think they are saying that having this reduced exposure causes a predominant and more of a kind of exaggerated T helper 2 response to allergens. Okay, and then moving on to the clinical features. Oh yeah, by the way, guys, any questions along the way, just do pop it in the chat. Feel free to at any point. So going on to the clinical features, so we're looking at the symptoms first. So if they're having this episodic shortness of breath, so now and again, it's not like a consistent, like they're constantly, oh, sorry. Oh yeah, sorry, that's fine. I just realized I couldn't see this Q&A thing as well. Cool, that's fine. Okay, so sorry, technical difficulties. Symptoms wise, so episodic shortness of breath, a dry cough, wheeze when they complain of chest tightness, and of course features of atopic disease, so eczema, hay fever, allergic rhinitis, when they just like wake up with a cold most mornings. And then signs to look for is this diurnal peak expiratory flow rate variation. I'll go into that in a bit more detail in a little bit. And then dyspnea, so like shortness of breath, and like difficulty breathing, and then wheeze. You'll hear an audible wheeze, or you might hear it on auscultation also. So going back to our little boy who's at the GP with his 5-day history of this breathlessness, wheeze, chest tightness, where we had the sore throat a week ago. And then he said that, again, history, very important. He said that prior to this, he would occasionally get wheezy with this dry cough, particularly worse at night. So other than this history of eczema, he's otherwise fit and well. An examination is unremarkable. So if we can go into our second question, which is, what is the first line investigation for this patient in the diagnosis of asthma? So would you do peak expiratory flow rates, bronchoscopy, chest x-ray, fractional exhaled nitric oxide test, or spirometry with bronchodilator reversibility? I will give you, oh, sorry, I just realized chat is disabled. I did not know that. I can definitely see some answers. I don't know if that's just me. Okay, still go ahead and reply because I can see your answers. Maybe you can't see each other's. But yes, please go ahead and answer. I'll give you like 10 seconds and then we'll move on to the answers. We've got someone saying peak expiratory flow rate. Okay, let's move on. So it is spirometry with bronchodilator reversibility. So let's go into a bit more detail. I'll skip this one. I'll go straight to our side here. So when it comes to investigations, we'll split it between children under 5 years and children 5 to 16 years. So under 5 years, it tends to be, the diagnosis tends to be based on clinical judgment with regular reviews. We don't usually diagnose children with asthma under 5 years, just because there's other differentials that float around, such as viral induced wheeze, which is a lot more common in that age group. And also because they're just not able to do the investigations we would need in order for us to diagnose them for sure. So age 5 to 16 years, spirometry is our first line. That's what you would do for diagnosis of asthma. Whether it's done, I don't think it is as much, just because there's not enough manpower for everyone to be doing spirometry on children, because it maybe it's a bit time consuming, but this is what we're meant to be doing. So the values it shows should be that the FEV1 to FVC ratio should be under 0.7 or 70%, and that's because it's an obstructive disease, not a restrictive airway disease. So if your spirometry has shown an obstructive airway disease, then we would do bronchodilator reversibility. So you'd give the inhaler to see what happens, and then that would show an improvement by over 12%. In the case that the spirometry is inconclusive, or say you've got the obstructive spirometry but the BDR is inconclusive, then we would go on to the fractional exhaled nitric oxide. And this just works because when there's inflammation, you release more nitric oxide. So that is over 35 parts per billion, and that's a positive result when it comes to in children. And then finally, the PEFR. So you do this multiple times a day over 2 to 4 weeks. It's more of a role, I'd say, in acute asthma than chronic asthma. I think it's definitely a good one to do alongside because it demonstrates it further, but it's not a must. But I think definitely in acute, we use it a lot more, and I'll definitely do a teaching session on acute asthma later on, and we'll go into that in a bit more detail. But I've just crossed off one bit here, and that's because I'm going to lead on to our next question. And that is here where the child's spirometry and FeNO results are inconclusive. And so we do the serial PEFR readings. Which of the following suggests a diagnosis of asthma? And I'll give you, again, like 10, 15 seconds to answer, and then we'll go from that. Give you like 10 seconds or so. That's all right. I'm literally just counting to 10, so it's not probably not very good. We got someone answering. Cool. Okay. So the answer is, yep, you're correct, Bethany. It's over 20% variability in PEFR. So that's what we're looking for when it comes to what indicates a diagnosis of asthma. So just to break down the answer a little bit more, so serial PEFR may be performed in it if we've got inconclusive results, as we just mentioned. So consistently low PEFR, not really, because as we said, we have that diurnal variation where it's worst at night or in early mornings. So high PEFR, again, not really something because it tends to be low if anything. So values, we tend to stay away from actual values itself, just because I'll quickly go through this and then I'll answer your question, Giovanna. So yes, so values, why we don't particularly use them is because it all varies based on gender and age and height, and so it can vary. And so that's why we do it more as like a percentage as opposed to this is the value. We do keep a record, or GPs will tend to keep a record of what their normal, what their baseline is, so that if they were to have it in an acute setting, we would check to see what the percentage, how much it might have dropped in the acute setting. So that's when I guess the values themselves will play a role, but not always. And also technique is a big thing. Like I've seen children where you ask them, you show them very well, but they're still just not able to do it because of poor technique. So yeah, that's why we don't really go as per the numbers too strictly. And then finally, the FEV1, FVC, that's the ratio. That's an example of spirometry results, not for PEFR. Someone just said, what's the investigation for over 16s peak flow? Why is it peak flow for chronic? Yeah, mainly a peak flow for chronic because so our first sign tends to be the spirometry, because as I said, this is what will show what kind of a disease it is, that it's this obstructive picture. I think PEFR, just because there's so many other human factors involved, as I said, technique is one of them, and then it's more over a longer period of time. I think it's definitely a good addition to have from any respiratory pediatric consultant I've spoken to. They always hone in to you to say, get a peak flow and do the peak flow on them, because it gives you a very accurate reading of where they're at and it shows you a good improvement. But it's more because it's a constantly changing value based on what their baseline is and what they are acutely. It works better in that setting as opposed to just how they are at their baseline I know it might not have sounded very clear, but drop me another question if it doesn't quite make sense, and I'll try and explain it again. That's okay. And what's the investigation for over 16 peak flow? I cannot remember what it is for adult medicine, I'm not gonna lie. I'm pretty sure they do spirometry as well, because I've done spirometries on adults, but you'll have to maybe let me know in the next session if you find out, and I'll try and see as well. Cool, so let's move on to the management. So children under 5 years old. So when it comes to management, and just for like exam purposes, there's NICE and there's BTS guidelines. In general, what I did was I just chose a guideline, stuck to it, revised it, memorized it, went with that. Because what I found from experience is that unless your med school tells you otherwise, or unless people who've done the exams tell you otherwise, to learn both, which is quite mean, they don't vary so much that if you were to get a question, it shouldn't be between choosing, like, whether they shouldn't be going, would NICE say this or would BTS say this? They would just say, as per guidelines, which would be the next step. And they are similar enough for you to be following the kind of the same kind of medication. So we're going with NICE at the moment, and this is because I use this at my trust as well, so that's what I'm going with right now. So with under 5 years old, I prefer this because it's a lot easier to follow and there's less steps. So step 1, newly diagnosed, you start with a SABA, a salbutamol, a blue inhaler, and remember they're children, so they need the whole mask and gear to be able to give them that. And then step 2 is if it's uncontrolled, or say you caught a child with newly diagnosed asthma with symptoms over 3 times a week or with nighttime waking. So then you would give the SABA as well as a trial of a moderate dose of ICS. So that's the inhaled corticosteroids like beclometasone for 8 weeks. So if after 8 weeks, you're going to stop it and you just monitor them, and if you find that if there's no improvements in their symptoms, then it might be that there's an alternative diagnosis involved here. But at the same time, and this could even be something like, I don't know, if you had a child with viral induced wheeze, very similar in terms of signs and symptoms, but not so much this, not so much the interval symptoms. But say you do have a child with viral induced wheeze, they're probably not, it might not have the same effect as it would with asthma. So, but they've come back within 4 weeks, then you just restart the inhaled corticosteroid. So it probably is the brown inhaler, but at a low dose, or the orange inhaler, but at a lower dose. That's under 200 micrograms. If the symptoms have resolved, but they recur after 4 weeks of stopping, you just restart that 8-week trial of the moderate dose, that 200 to 400 micrograms of ICS. So step 3, say you do it, you review them again, maybe after like a month to 2 months. If it's still uncontrolled, if they're still having these symptoms, and it's mainly these symptoms that we're looking at, this having to use your blue inhaler around 3 times a week, or you're getting those nighttime waking episodes. So then you go on to step 3, which is starting the SABA. So you have the SABA already, say you're already on the pediatric, the low dose of the ICS, and you start the leukotriene receptor antagonist. So that's montelukast basically. And then step 4, if it's still not improving, you would stop the montelukast and you would refer them on to a pediatric specialist. And then moving on for management, again, children 5 to 16 years old this time, a lot longer. I think more similar to adult medicine, but there are definitely differences, because I remember writing them down separately and sticking them on my wall, because the only way I memorized them was memorizing like 3 steps at a time with them, because they just kind of merge into one. So step 1 is, again, as we did with before, we would start, sorry, I'm just trying to move it around because I can't see. Yes, so newly diagnosed, you would start with a blue inhaler, salbutamol, which is a short-acting beta agonist. And then step 2 is you would trial the pediatric low dose this time, but again, there's not that time frame as there was before, so there's not that 8-week time frame. You would just trial it, and then you'd review them again, and then say there's no improvement, or you have again, it's all about those interval symptoms that are persisting. Then you'd go with the SBA plus a pediatric low dose ICS, so again the same as that, plus the Montelukast. So again, has stayed the same as the 5-year-old one till now. And then step 4, so instead of referring at this point, as a GP, you'd probably continue to try and change the medication. So you'd have the SBA, the pediatric low dose ICS, and the and the LABA, so a long-acting beta agonist, and you would consider stopping the LTRA, so you stop the Montelukast if you feel like it's not really made much of a difference since adding it at that point. And then step 5 is SBA plus switching the ICS or LABA to a MART. So a MART is basically a maintainer and reliever therapy. So it contains that maintenance with the inhaled corticosteroids, as well as the LABA aspect, which is a reliever aspect of it. So they're just combined into one inhaler, and that's called a MART. And so step 6 involves changing that dosage, because up till now that dose of the ICS has remained at a low dose. So now we're going to increase to a moderate dose, either within the MART or if they've chosen to have them separately. And then step 7 is when I think you get a bit tired of doing it, of changing the medication so much. So you've increased it to a high dose. You can trial an additional agent like theophylline, but those are drugs that you definitely look towards referring at this point. So we'll just go ahead and refer when it comes to step 7, but you might want to trial them on something in the background. So going back to our little boy, so remember he was our 7-year-old boy, nearly done, guys. So this is our last question. So 1 year later, our little boy is reviewed in clinic again, and he's now on low dose beclometasone and PRN salbutamol. So that is step 2. Sorry, just gave all the answers. And then, but his symptoms are still poorly controlled. So what is the most appropriate step? If you guys would like to write in the chats, I can still see them, even if you don't quite have access to the chat. I can somehow see some answers. So I'll give you like 10 seconds. Cool. Yay, well done. Yes, so you would start Montelukast. So just breaking down each of those answers. So increasing the beclometasone dose isn't something you would do just now. That's kind of a later on, as we saw later on, approach, because you would have this alternative maintenance therapy, maybe start a MART and a LABA in between as well, and of course Montelukast too. So Montelukast, how it works is it targets the inflammatory mediated pathway that results in that bronchoconstriction. I think at this point, BTS states a LABA would be an alternative. As I said, the questions don't tend to try and catch you out in terms of being like, oh, you should know both. They probably wouldn't give you something if they're completely stark differences between the two guidelines. So yeah, and oral steroids, we tend to use them in exacerbations as we do with adult medicine as well, or it's in very, very poorly controlled asthma. So a Montelukast would be commenced definitely before considering anything like long-term oral steroids, just because they come with so many other health effects. And then tiotropium, so that's long-acting antimuscarinic. So we see that a lot in COPD. Occasionally consider it in asthma exacerbation. And finally, oral aminophylline, also a bronchodilator. We do tend to use it a lot in, well, not a lot, but we tend to use it in severe asthma exacerbations, but also can be commenced in chronic settings under specialist advice. So I think that's everything. So that was, wow, it's actually 7. So that's a very rapid kind of whistle top tour about asthma, about chronic asthma. And I know it was quite fast, but as I said from the beginning, just that's how I found was helpful, was that short, snappy scenarios are always a lot better to get them into your mind. And asthma is definitely very current because the winter months in peds is when you'll see a lot of asthma exacerbation. So it's good to kind of have the foundations of it as well. If you have any questions, feel free to ask in the chat now. As I said, I can still see your questions, so, or like your answers, so go ahead even if you can't see them amongst yourselves. And then there's my email there as well if you wanted to ask any particular questions. I've also got a feedback form if you could kindly fill in. So that we can talk about if there's any particular peds topics that you want me to do in particular. I think upcoming ones I've got is like bronchiolitis, croup, so quite wintry topics. But if there's anything else, whether it's like heart related you want me to talk about, then go ahead and ask in there. But yeah, any questions at all? Just give a couple. No worries, thank you. And then yeah, just let me know if there's any ways in which I can improve that you'd want me to do better. Oh, what's the difference of obstructive versus restrictive disease? So it's all about kind of how let me try and find a link actually, or like an image that will help me describe this. But I'm not good at technology, so that's not good. So okay, never mind. I can't seem to find how to share my screen. So essentially when it comes to obstructive and restrictive, so restrictive, as we said, is an example is asthma or COPD, and that's when you get these values of the FEV1 to FVC ratio of under 0.7. So with obstructive lung diseases, it's hard to exhale all of the air in your lungs, so it's hard to expel it. So you still, that's why say in x-rays you might have this hyperinflated image, because you will still have air collected, still air in there, because you're not able to exhale it all out. And then sometimes in like COPD, what if you're going back to like ABGs and things, you'll see like a raised CO2 because you're not able to exhale it out. Whereas people with restrictive lung diseases, with them it's more the fact that it's harder to breathe it in and to expand it in the same way. So they don't have the same issue as exhaling. It's more the fact that when it comes to taking it in, it's because it's kind of tight and a bit, it's restricted, it doesn't expand in the same way that it would do normally. And so you tend to have the same symptoms or similar symptoms, but in testing you will see that they are definitely different. Is that okay? But a very good question, because it's usually I've come across it in exam questions. No worries. Any other questions? Cool. Okay. Well, thank you very much. As I said, I'm happy for you to email me or pop anything on the feedback form. Just let me know about what you would like to learn about next. If there's anything in particular, if there's anything you want me to go into detail about. Yeah, hope you have a lovely evening. See you all soon. Bye.